RTA type 1 is known as distal RTA, whereas type 2 is known as proximal RTA. Why distal RTA? Because this is the defect in the alpha intercalated cells of the cortical collecting duct. So what happens? These alpha intercalated cells have H plus K plus ATPase channels, which will excrete H plus and take in potassium ions. Now, when there is defect in these channels, the main function of these alpha intercalated cells are that they acidify the urine. So when this urine is not acidified, this defect will lead to significant acidosis in the body because H plus is now not being excreted out. So this significant acidosis will cause hypercalciuria and salt and water wasting. Along with that, hypocytraturia, which predisposes to stone formation. This hypercalciuria is also predisposing to stone formation, and there is calcium deabsorption from the bones. This will also cause stone formation. Due to this salt and water wasting, what is happening is uh, there will be secondary RAS activation or secondary hyperaldosteronism, which will again cause hypokalemia. Now we come to RTA type 1, that is proximal RTA. Proximal RTA is a defect in the proximal convoluted tubule. What is the function? We all know that it is involved in sodium dependent amino acid, sodium dependent glucose, sodium dependent phosphorus transport inside. Now, proximal RTA. Proximal RTA is also known as Fanconi syndrome. That is RTA type 2. In RTA type 2, there is global PCT dysfunction. So, what is the function of the PCT? We know if there is PCT dysfunction, then there will be amino aciduria. Amino acid will be lost in urine, glycosuria because of the glucose loss in urine, phosphaturia, phosphate loss in urine, and also there will be bicarbonate. This amino aciduria will lead to wasting of the muscles and the growth retardation, and phosphaturia will cause rickets. Bicarbonate causes acidosis, but this acidosis is not as significant as the acidosis which was caused in RTA type 1, and this acidosis will again lead to hypokalemia by secondary RAS activation or secondary hyperaldosteronism. This leads to hypokalemia. This acidosis is not significant because the bicarbonate which was lost in the PCT during transport from PCT is again reabsorbed in the distal tubules. So if we want to draw a final conclusion, RTA type 1 and RTA type 2, what is the main difference? Main difference is that there will be phosphate loss in RTA type 2 and phosphate loss is not seen in case of RTA type 1. So this phosphate loss leads to rickets in RTA type 2. If we see, calcium loss is there in RTA type 1, but it is not present in RTA type 2. Calcium loss will lead to rickets in RTA type 1, but this rickets due to phosphate loss is more severe. So the rickets is more severe in case of RTA type 2 or proximal RTA. And if we see, the acidosis is more severe in case of uh, type 1. This is less severe, and hypokalemia is also more in case of type 1 than type 2, and amino aciduria is present in type 2 only, not present in type 1. Thank you.